Good morning, everyone. I welcome all of you in this 9th Diagnostic Day. Because of the encouragement received from all of you, we are able to hold this 9th Diagnostic Day. This we started at the beginning of this year. Simultaneously, we also started pathology update and microbiology update, and in those also we are receiving very encouraging response from all of you. Thank you very much for this. And today we will discuss point of care testing. I think all of you will agree with me. This is very essential in the patient care. But there are certain concerns with this point of care testing. So in this lecture, we will discuss, and the coming two lectures, one by Dr. Suryasnata Das and another by Dr. Sohini Sengupta, we will discuss what are the areas where we can apply this point of care testing and what are the advantages and what are the limitations of various point of care testing tests. And people are working very hard in this area, and recently it has been included in the fourth edition of ISO 15189. When this fourth edition will be released, probably in the November, then you will find it is also included in the fourth edition. And whenever this fourth edition will be released, it will supersede that ISO 22870, and that will no longer be valid, because then medical laboratory will use ISO 15189 to address the quality assurance requirement of point of care testing. But before starting, I would like to know whether I'm clearly audible or not. Ajita Dubey, please unmute yourself.
Hi, sir. Good morning.
Am I clearly audible?
Yeah, you are audible, sir. Very nice. Thank you, sir.
What is this point of care testing? If you see what we do in our laboratory, we try to fulfill these two requirements of clinician. They expect all reports within reasonable turnaround time so that they can take appropriate decision, and precision and accuracy. They need correct report. Accuracy means how close our results are to true value. And precision means if we are testing for the multiple times, same sample, there is no significant variation. And this accuracy and precision should be documented. It is not like that we are saying there is our reports are accurate, but we shall have data with us. For that, what we do in our laboratory, we keep sophisticated equipments, well-trained technicians. We are processing large number of samples in a short period with excellent reproducibility and precision. We have quality management system in place. For this, we use ISO 15189. We apply for accreditation. In different countries, different accreditation bodies are functioning. And our laboratory is managed by lab specialists. All tests are supervised and approved by lab specialists, either pathologists, microbiologists, or biochemists. Then these are released. And we also provide advisory services. If suppose some clinician want to know what particular test is required in a situation, how a sample shall be collected, how frequently this test shall be repeated, what is the interpretation of a particular test, we are providing all these services. And what is the present scenario in healthcare? A lot of changes are happening. A lot of developments we are seeing in healthcare and in patient care delivery. Nowadays, there is more patient-centered approach, rapid triage of patient, whatever treatment modality is required, whatever diagnostic test is required for a particular patient, that shall be available close to patient, and people who require urgently, they should get some priority. Sometimes people talk about one-stop clinic. Patient is coming to clinician, and certain tests they are performing in their clinic only, and they are taking decision accordingly. Hospital people, they are trying to consolidate hospital facility. Everything is available at one place, and also we want to reduce length of stay in the hospital so that there are less chances of receiving hospital acquired infection. It is economical also, and patient also feel comfortable. Now for this present scenario, how we can fulfill this? If we can develop certain tests close to the patient, or you can say bedside testing. This is also known as point of care testing, and this doesn't require any permanent dedicated space. You are keeping equipment in one place, and most of this handheld devices you are bringing close to the patient and performing tests. Immediately you are getting result, and you are taking appropriate action. But for this, we have to understand. If suppose 100 patients are there in the hospital, which particular group of patients, or what are the patients which need, first thing is they need blood testing, and what are the tests need to be performed. Then we have to understand how we are performing these services at present, these laboratory services, how these are delivered at present, and are these really meeting the clinical need? And if the clinical need is not being met, then how we can rectify this problem, and what all has been done to rectify this problem. Another thing is access to laboratory services difficult for the patient? If suppose for some condition they require frequent monitoring, like if they are standardizing the dose of insulin, plasma glucose monitoring, or blood glucose monitoring, or PTINR, or some other test, and whether this is discussed with the laboratory or not. And another thing is, if we develop point of care testing, will you be able to provide rapid or effective diagnosis or treatment? Whether this will provide some clinical benefit to the patient or not, economic benefit to the patient or not, or will it be cost effective alternative to laboratory monitoring? This we have to see. What are the benefits and advantages of point of care testing? There is decrease in the turnaround time. Results are available at the point of care only and immediately. There is no need of any sample transport. Sometimes what happens in some hospitals, if suppose this ABG facility is available at one place, so you may have to transport samples from different areas to that particular area. But in most of the cases, particularly in handheld devices for PTINR or glucose monitoring, this sample transport is eliminated. All these things are available close to the patient, and we can monitor treatment. We can measure certain parameters at bedside only, and this helps in immediate clinical decision making. There is decrease in the pre-analytical error. Patient feel more satisfied. Sometimes what happens, certain things may not change the decision or outcome, but it improves patient satisfaction. Sometimes improved clinical outcome, morbidity and mortality, reduced number of clinical visits, reduced length of hospital stay, and we can optimize drug treatment also. If suppose we are monitoring PT-INR, we can modulate drug according to the value observed of this PT-INR. But there are certain limitations of this point of care testing. You can say sometimes not very good analytical performance. These tests are performed by people working in various capacities, nurses, residents, doctors, other staff. It is very difficult to control the quality. And another thing is there is insufficient quality control material for this point of care testing, and no lab specialist involved in the interpretation of results. There is increase in the cost. It is available for the limited test. And sometimes what happens, all these things are not documented properly. The results are not documented properly. Somebody is performing, suppose, glucose test by glucometer, and suppose glucose is 268, they take decision, but there is increase in the dose of insulin in the case sheet, but sometimes no documentation of this plasma glucose. So after that, no documentation is available, which is telling you why insulin was increased. So what is required? We shall have some system of quality assurance to this point of care testing. A process of point of care testing should be developed in support of risk management and reduction in medical errors, because these things are not released by laboratory people. If suppose some nurse is performing test and she is telling to clinician and they are taking decision, if there is no appropriate quality assurance, there may be some medical error, and patient may get treatment which is not required or may not get treatment which is required. So there is a risk, patient safety is compromised. There should be some interdisciplinary committee. In this, laboratory people are involved, clinicians are involved, quality assurance team is involved. You shall have system of training people who will be using this point of care testing devices. And data management is very important. Maintain data so that it can be used as a mechanism to improve the quality of point of care testing, and develop, as we develop quality indicators as per our ISO 15189 clause 4.14.7, develop some quality indicators for point of care testing also, and monitor those quality indicators and see whether you are able to provide good care point of care testing or not. For this, introduce a system of securing point of care testing operations, their integrity and instruments. You have system who will operate and how the person will operate. They are trained. Nobody is tampering this point of care testing equipment. These are well maintained. And also these operators, they are trained, and then you are checking their competence, whether they are able to perform a particular test in practical situation or not. For that, you are providing training. After that, post-training evaluation, you are developing some internal quality control system for your point of care devices, and how we can prevent error. For this, good monitoring is required for this point of care testing devices, and whatever critical information you are communicating to clinician, you have to see those informations. If suppose you are telling telephonically to address the requirement of clause 5.9.1 of ISO 15189, this information is reaching only to authorized person so that confidentiality of the patient is maintained. And you have a system. You have a system. Ki there is read back policy. Whatever you are informing them, somebody reading and then telling you, yes, what exactly they have heard. Participation where it is available, proficiency testing program or EQUAS, laboratory should participate in that. And when you're selecting point of care testing analyzer, see what is your expected workload. Who is going to use the equipment? What level of analytical accuracy or precision is required? And also see if multiple users, they are using the machine, results are comparable between operators. And whether some processing is required or sample can be used directly. Then develop some quality control system also. And also see where you will keep that equipment and it's consumable, so that people who have to use that equipment, they know where they are supposed to keep the equipment and where a particular equipment is lying, so that there is no confusion. If suppose some appropriate power supply is required, that is available, some refrigeration is required, that is also available. And also evaluate this equipment and time to time compare with the laboratory equipments, whether you are getting comparable results or not. And you also have to understand limitation of a particular equipment. And you shall have system as we perform maintenance of other equipments as per your clause 5.3.1.5, we have some system of maintenance in this point of care testing also. This was a basic introduction of point of care testing. Now Dr. Suryasnata Das will deliver talk on point of care testing in microbiology. Dr. Suryasnata Das is currently working as lab coordinator and associate director in microbiology and coordinator of infection control at Jaypee Hospital, Noida. She is an MBBS assessor also. She is expert in managing operations of the laboratory. And she is also expert in routine diagnostic procedures in microbiology and molecular techniques, such as diagnostics in microbiology and molecular biology for infectious disease and hospital infection control. Previously, she has worked with many reputed institutes like Jaslok Hospital and Research Center Mumbai and GS Seth Medical College and KEM Hospital Mumbai. These are two very reputed hospitals of Mumbai. Right, so now I am ending my session here. Now Dr. Suryasnata Das will start. Good morning, Dr. Suryasnata. You can unmute yourself and start with your presentation.
Thank you, sir, for the generous introduction. I would be handling the topic of POCT in microbiology, where I would be dealing with microbiology per se, microbiology, serology, and a little bit of molecular biology, because I realized when I was going through, there's a lot of POCT now in microbiology also, and it's a huge thing. So we'll go step by step. Any questions I would prefer taking at the end. Am I visible? Is my screen
Yes.
visible?
Right. Now
Yeah.
it is okay. Full screen.
Yeah. So I think sir has already given a very beautiful introduction to point of care testing. I would be also going through the same from a microbiologist perspective, which may be a little different. Mechanism, it's why does a healthcare system have a point of care testing? It's to make the system more efficient in deployment, to get the results faster, to have better manpower management, to have better logistics, etc. And the point of care, I was quite amazed to see the numbers. The market for point of care testing has gone over $29 billion globally in sales, and it is expected to grow by another $10 billion was expected in 2020. And I'm sure with COVID coming in and so many point of care tests in COVID, both in virology, in serology, and in the molecular section, the market would be much bigger. I could not get the recent numbers, but I'm sure it would be much bigger. So you deploy it, you make the lab independent diagnostics tests, and major tests which are being used in the last couple of years we all know in India, we use syphilis, we use malaria. In TB, we have had not exactly point of care testing, very close to point of care testing. And in fact, some of the tests which we use in the lab also to identify the mycobacteria, to speciate which species of mycobacteria it is, they are like point of care testing samples. Really sorry for the interruption. Yeah, so this is where we work, and the different their point of care testings have been given different name. You have tests which are done bedside, which are done near the patient in the ER. There are some point of care tests which are done at the physician's office. Say you have a sore throat, you go to the physician office. There are a lot of tests, though not used much in India, but there are a lot of tests which can be done for Streptococcus pyogenes to see, and you get a diagnosis at the physician's office. Then the other is to decentralize testing, to reduce your TAT, your turnaround time for reporting. Then other than that is the offsite testing, or where you have blind spots, where the normal healthcare labs cannot reach, rural areas, interiors, where sophisticated instruments are not available. So offsite testing in camps, in healthcare screening centers. So there are various places where these point of care testing kits are being used. The WHO proposed a general framework for what happened, because there were a lot of POCT tests, and we didn't know how they have to be designed. The biggest challenge in POCT tests is, even if you see in our market, and I'm sure you all work in the lab, lots of kits for each test. So to streamline that process, WHO came up with a term called assured. So assured was the acronym for A for affordable, S for it should be sensitive, S again for being specific, and it should be user friendly, as point of care cannot be complicated, because you may not have very trained people who would be, or very technically competent people who would be doing sometimes at the offsite location. Then it should be rapid, but at the same time it should be robust and equipment free as far as possible, and it should be deliverable. It's not that you develop a point of care testing which you cannot report. You should have the mechanism wherein you can report it confidently. Then Pi and Group, they had testing profiles. Again, as I said, they have different names. So they categorize the point of care testings into different categories. They named them into different types: type 1, type 2, type 3, type 4, where type 1 was which was self-testing based, where type 2 was where you go to the community and do the testing, and usually done by a healthcare worker. Then you have the clinics one at the doctor's clinic where the testing is done. Then you have type 4, which is done in peripheral or satellite labs, and type 5, which is done in hospitalized patients like your ER, or you have a separate lab for your ER, which gives you stat reports, faster reports. So these are which are called POC. You sometimes call them point of care testing labs, specially designed even in the hospital setup. Then what is the application of a point of care testing in a microbiology lab? Look, it should affect and predict the outcome, and it should quickly provide a highly targeted therapy. Your intent is to identify the disease or the infection or the pathogen or the pathogenesis of the disease, and then you should be able to immediately give the correct therapy. And in microbiology, it is very important because it ultimately leads to targeted therapy. And we all know in microbiology, we are talking about antibiotic stewardship, we are talking about antimicrobial stewardship, where we are talking about the antibiotics, the antiviral, and the antifungal. If you don't know the causative organism, the general tendency is, which I understand from the clinician point of view as a clinical microbiologist, that first intent is to save the patient. So if you know the pathogen, the therapy would be much more targeted, much more focused, and would go a long way in the antibiotic stewardship. And immediate diagnosis sometimes can be cost effective for the patient as well as for the hospital, because you can triage a patient. Let's take an example. During the COVID pandemic, we were all triaging COVID patients. So a fast report would help you triage. You were not required to keep the patient in triage for a long time. You do the COVID test. If he's COVID negative at that point of time, patient can be shifted to a non-COVID area. And if he's COVID positive, the patient can be shifted to the COVID area. So these are important things which help to reduce costs. Rapid recognition of infection control protocols. There are many screening methods where they screen for MRSA, they screen for VRE, they screen for carbapenem resistant Enterobacteriaceae, and you can easily put your infection control practices in place. Or even in a viral infection, how do you know what kind of you require a contact precaution, you require a respiratory precaution, you require a droplet precaution, all that can be defined very well. Then for any infection of any disease, surveillance plays a very important role. So surveillance should not only be focused in the higher setups where there is all the facility for diagnosis is available. Surveillance is also important in the interiors, where you need to know which infection is prevailing, where there's an outbreak of malaria, where there's an outbreak of leptospira. So all these things are very important. The other important thing is, end of the day, we are serving the patients. If the patient is not satisfied and we are not able to interact in a fast way with the patient, the purpose of this, the purpose gets defeated. So therefore, patient satisfaction and interaction is an important tool. Increase accessibility to care by providing testing. I told you, you can go to the interiors, into geographically challenged areas, in economically or rural areas, backward areas where probably a sophisticated lab has not been set up till now. So these are important things where a POC test in microbiology has a role. Various technologies. Then the important thing is, in microbiology, what are the techniques which are being used for POCT testing? Various technologies have been used for the POCT testing. Obviously, we all, I think, have seen the lateral flow assays, the latex bead based assays. So, and I think in today's era, the most rapidly and rampantly used technology is the lateral flow assay, where the microbial antigen or the antibody is bound to the nitrocellulose nitrocellulose membrane, and then the antibody, the bacterial or the antiviral antibody to that particular antigen is put on it, and then the human antibody goes and join, and we sandwich, and there's a label. Usually it's a colloidal gold label. Now you're getting non-gold labeled tags also, and you put the sample and the buffer, and then they move, and then you detect the see the assay. So, and the ease is it is an inexpensive assay, but sometimes these assays, though they keep working, they keep refining the antigen and the technology and try to increase the sensitivity as well as the specificity, but many a times these kits do not have good sensitivity. And the other challenge with which I face, at least in my lab, is that there are a lot of lateral flow assays which are available for typhoid, for malaria, for dengue, for leptospira, for scrub typhus, for every possible infection we can think of now. But the challenge is the quality of these lateral flow assays. Sometimes they are not sensitive enough, they're not specific enough. So you need to look into that, and you need to validate the assay. The next is your nucleic acid based tests are also, it was unheard of that nucleic acid tests can be called POCT tests, but with the closed systems coming in, the technology improving, we being able to use, other than the classical PCR, we are using the loop mediated isothermal PCRs. So all this, the isothermal PCRs have reduced the time to report, and they have also reduced the equipment requirement, and have actually got molecular testing to a level where it can be put in the point of care testing, which was unheard of few years back. Then there is the microfluidics based test, and now in fact the microfluidics tests are work is being done. There are quite a few kits available also, which one of them I would be talking later would be in COVID also. There's a microfluidic based test, and other than that, in molecular also, your gene expert is based on microfluidics. So these tests are very compact. The fluids are placed inside a cartridge, and the analyte, everything is inside. The sample goes and wets these cartridges, and you can take these cartridges. Some of them have been designed in such a way they're so simple that it can be put on an app in the mobile, and it can read it, and you can get your results. So this makes it very user friendly, techno savvy, as well as helps to reduce the cost of instrumentation, because mobile is by default now has reached rural India, has reached every corner of our country, and globally also. The key features to distinguish them from the traditional lab tests is, how do you say that, many a times there's a confusion, because many a times the bigger labs or the core lab also uses a lot of these point of care testing. So how do you define which is a point of care testing? Some of the point of care tests can be done even in the core lab, but the classical definition or the classical understanding of a point of care, where they do need significant lab infrastructure, specialized staff to order these tests. You don't require really specialized. I'll come to the lab technician part and what is the advantage of having a trained person versus a completely untrained person. And they're often, these tests are able to deliver fast, though they say 1 hour molecular tests. Some of them may take more than that or little lesser than that, but it is good enough, where molecular tests used to take sometimes even a day, or maybe 4 to 6 hours, 7 hours. Now we have come down to say 1 hour, 90 minutes. So it is an achievement, and they're designed in such a way that they are easy to use and easy to interpret. They do not have any complicated results, and interpretation is not an issue. Now, where all they are used, we use it every day in our day-to-day microbiology diagnostics. Some are direct microbiology and some are indirect. I say for a microbiologist, bread and butter for a microbiologist is urinary tract infection and urine culture. But in urine culture, you also have to look at the pus cells, the nitrate present in the urine, for you to say that it is classically a urinary tract infection, and you have pyuria and bacteriuria both. So indirectly, you have the nitrate test, which is a rapid test. It's simple, and studies have shown that in symptomatic in men, when urine nitrate was done, the sensitivity was 38% and specificity was 84%. And this false negative results, or this false results could be because of lack of dietary nitrate, reduction in nitrate owing to diuresis, and because of some organisms also which give false, and we do get these organisms now in urinary tract, especially Enterococcus, which is a problem for many microbiologists. So there are challenges with all POCTs, all that I'm trying to say. So we just can't blindly follow them. So we have to still look at the technical expertise, and POCT cannot be left as saying that it's point of care testing and the lab does not need to see it. The flexicult. The flexicult again is a very unique chromogenic agar plate which is divided into 6 quadrants, and one big quadrant is for the culture to be put, wherein you can, it's a color based test on basis of which you can see the growth of the and you can quantitate the semi-quantitate the bacteria in urine. The other 5 quadrants, if you look at it, they are impregnated with antibiotics. So basis on in which quadrant which bacteria is growing, you can say whether it will be susceptible to the antibiotic or resistant. If it grows, it is resistant. If it doesn't grow, probably it is susceptible. Though this has not got an FDA approval, but I thought it was a very novel idea for urine culture to be made easy, to be made accessible to locations where you do not have the technical expertise to interpret it. A microbiologist is not there everywhere. This may be an option, but yes, more work needs to be still done. Now coming to the respiratory infections. In the respiratory infections, I think COVID and the influenza infections have taught us a lot in the last 10-15 years, and COVID in last 2 years. The molecular assay for SARS, there are a lot of molecular assays, combined assays through Gene Expert has, where you can detect COVID, you can detect your SARS-CoV-2, your influenza, and the respiratory syncytial virus in one go, and they have a sensitivity close to almost 97.8% for influenza, and similar results for RSV, and for influenza, in fact, the specificity is in fact close to almost 100%. So these are combination assays which are available right now for the various platforms, and primarily on Gene Expert. Then Abbott also has for RSV. So there are different manufacturers who have these rapid POCT tests, which we call sometimes as rapid tests. These are available in the market. And then not to forget, we have our own homebrew MolBio, the TrueNat, which has its kits for the various respiratory pathogens. It started with mycobacteria, now for COVID, and for other pathogens as well. And they are very, very easy. In fact, Epistem, another company which had almost like an handheld instrument which can be isothermal assay, which could detect in fact up to 2.5 to 10 power 4 colony forming units of mycobacteria, which is a commendable thing for a handheld instrument. But yes, the sensitivity was low, so most of these POCT tests have not been launched completely, especially Epistem, because of the low sensitivity. But there is a flip side to it: low sensitivity versus the advantage in resource challenged places where it is difficult to reach, or to have a better outreach program. Even if you are able to pick up this 45% people versus where you do not do any diagnosis but you treat empirically, probably this 45% still maybe, and there are articles which have evaluated the economic impact of this. You can go through them. The reference I put down, it has cross-referenced some of these articles, and it may work good. Basically empirical therapy versus some diagnosis in resource challenged. If you look at it, at the top is the Abbott instrument ID. Now we all would have seen the demo or would have read about it. This was able to give your RT-PCR, your PCR results within 15 minutes during COVID, and was very useful for triaging patients and giving a rapid diagnosis, especially during the second wave. And the next is the this is the Acura Lumira Dx. It is a microfluidic based, there's a microfluidics, there's a fluorescent tag to it. You just load the sample and the reagent, and it goes by microfluid. Just there's a simple like your card machine, like your credit card swiping machine. The machine is that small. You just insert this and it gives a result. And this is a antigen based assay. And Acula, again, a PCR based assay through Thermo Fisher, which again did a PCR and a lateral flow both combined together. There's a cassette, you load the sample, it moves, almost looks like the lateral flow, and you can detect the PCR. The only challenge with these POCT tests where there were endpoint PCRs where you could not see what in real time the graph was, and sometimes there were false positives, or probably they were picking up very low load of virus, so the chances of false positivity was there, but still there was a huge advantage because you could at least triage most of your patients. And now the gene expert, which we all, I think, use for tuberculosis, we've been using for years, and it's a WHO recommended method. So again, it's a very microfluidic based system, very compact. There's a cartridge, there's a processing chamber. The chamber contains all your reagents, that is a primer, probes, buffers, and whatever is required for the extraction process. Then there is the amplification tube, wherein after that it moves to the end, and here the sample moves automatically, slowly with the as the sample moves, you load the sample and the sample goes into the chamber, and the dehydrated reagent which is there, it moves along with that. So this is a very compact thing. You load this onto the instrument, it goes into the thermocycling phase, and then you're able to see the PCR. And the advantage here is it is not an endpoint PCR. It is like the real-time PCR. You can see a graph and see what has happened during the PCR. The other important thing is, as a microbiologist, which is a concern, is your XDR tuberculosis, which is a cause of concern. And since we have a program where we are looking at the elimination of tuberculosis, Gene Expert has a kit wherein you have, which is again within 90 minutes, you will come to know that whether you have XDR tuberculosis, which is quite commendable for the few drugs, not all the drugs which can be used in the XDR tuberculosis, but quite a few of them which are very commonly used and helpful. So these are few tests which, as a point of care testing, rapid diagnosis, though here you require a little bit of instrumentation and specialization, but if we compare it to the conventional tuberculosis culture and susceptibility reporting versus the other molecular testing like your genome sequencing, these are POCT, they are point of care, they are very compact, very easy to handle, and very easy to use. Then coming to the respiratory infections, I gave you an example of Streptococcus pyogenes infection. And here, if you look at it, the sensitivity and specificity were, when compared to culture, were 86 to 95%. But somehow in India, this has not picked up because of cost reasons. Empirical antibiotic is cheaper. And most of these antigen-based assays have been slightly on the expensive side, and most of the institutes probably don't use this. There have been a lot of nucleic acid based assays also for streptococcal pharyngitis, which give results very fast. ID now has a kit which can be used for streptococcus, but somehow in India, because of cost issues, somehow this has not picked up. Similarly, in US for influenza, they are very conscious about influenza, so they use a lot of rapid influenza virus antigen based tests which give results in 30 days, which have a sensitivity close to 60% and a specificity almost close to 100%. So therefore they are able to screen their patients, and they are able to track such patients and give early treatment, and antibiotics can be avoided in such cases because most of the infections are viral. Now coming to the tropical infections, malaria, I think we all use in the lab. We use malaria kits which are LDH based, and they are HRP2 based kits where they can differentiate between Plasmodium species and Plasmodium falciparum. Most of these are immunochromogenic, or they are gold coated based, and generally we have seen that they are able to detect parasitemia counts up to 0.001%, and they are good kits. Then the other infections wherein we have a lot of bacterial kits. I'm not going to the detail of these, your enteric fever, Borrelia, typhus, rickettsia, Bartonella, leishmania, dengue. I've just named a few. There are many more which have come into the market, but yes, we need to validate them, we need to check them. The nucleic acid based testing are also available now for the tropical fevers, but yes, they are not available on the rapid kit base. But I'm sure they're coming up with the fever panels wherein we will be able to do it even in cases of fever. Now coming to the sexually transmitted diseases, which are mainly, they require rapid diagnosis because usually there is social bias, the patient will not come back repeatedly to you, and especially you need to also do it in resource limited settings. So it has to be fast and cost effective. So there are a lot of kids immunoassays which are available for chlamydia, Neisseria gonorrhoeae, Trichomonas vaginalis, herpes simplex. And the use of POCT in STDs is widely supported, especially in the Western world. They have, I will show you later how they have set up a POC lab which is completely automated. And the concerns over minimum sensitivity versus do exist there, but they are used safely, used as a standalone test. That is the important thing, because the patient will not go back to the core lab. So here the sensitivity of POCT test is very important, and the sensitivity, it's usually worked on to give a good sensitivity, but there are kits which vary from 12% to 100% sensitivity and 38 to 98% specificity. So we need to again look at the kits. The other important molecular assay which has a CTMG expert which detects your Chlamydia trachomatis and Neisseria gonorrhoeae by a molecular method in the STD clinic is also a useful POCT test in the sexually transmitted diseases sector. And POC and infection control, I have already highlighted. I'm re-emphasizing why is it important for the microbiologist, even in the other role which we play as an infection control specialist. Early triaging, appropriate use of antibiotics and antivirals also, and antifungals also, and early detection of resistance. Some of these rapid kits are now there for, like Gene Expert has a screening for MRSA, it has for VRE, it has CARBAR for screening. So these are all tests which will detect your resistance and would help you to fight and have better infection control practices in the hospital. Then comes the syndrome based panel testing. Now these point of care tests, everybody wants one shot and all answers. So they are able to detect multiple pathogens. They obviously add diagnostic value, and infectious causes of disease are broad and diverse. So you want to diagnose your bacteria, your fungal, your viral in one shot. So, and the balancing the time and the analytical performance is also, I think, one of the tests which is there in the market is your biofire film, and the QIAGEN QIAstat is also there to do the same thing. So if you look at it, there's a respiratory panel, there is a meningitis panel, there's a GI panel, there's a blood panel. So there are different panels which are available in these molecular transports. Then, as I told you, everybody wants a one answer in one shot. So this path, if you look at the biofilm, biofire film array assay, you have all the common viruses which cause infection, be it the corona, the other coronaviruses, the rhinovirus, the influenza, the parainfluenza, the RSV, and amongst the bacteria, you have chlamydia, mycoplasma, the atypically presenting and mimicking viral infection. These panels are there. And similarly for meningitis also, which is one of the most difficult things to diagnose, and the turnaround time of report is very crucial in meningitis. You may lose the golden hour, and therefore these panels are there. And similarly, the QIAstat from QIAGEN also has something similar, where it can detect the almost similar to your biofire, the most of the common respiratory pathogens in one go. How do these work? They are very simple. You have the insert, you have the reagent, and you have the sample. You add them, you mix them, very simple step. You inject the sample at the last step. There's a cassette there, and then you load it onto the instrument, and the instrument itself does all the steps automatically, and then the reports come out, and the report typically would look like this. The software automatically analyzes the graphs in the instrument and will give you whether it is whichever pathogen it is which is detected and which is not detected. So I would say it is very simple to do, easy to handle, and you get results. The biggest challenge with this point of care testing is the cost in our country. There are a lot of kits which have come up and which are there available, and the most common syndromic tests which have been there have been diarrhea kits, pneumonia, meningitis, vaginitis, asexually transmitted disease kits and tropical fever kits, which have come up, and they are done from various samples and they're available. Now, to set up a POC lab, I'm not talking about a POC testing in a peripheral area. I'm talking about in a hospital. You can set up a POC lab in the hospital as a stat lab. I'm talking in microbiology, because what happens, microbiology is usually believed to be sitting in the microbiology lab and doing the reporting. But even in microbiology, very much like biochemistry and very much like hemat, you have to be fast now. That is where the golden hour is established. So the location, you require to install it as close as possible to the emergency room. You should have a decent air conditioning and with a temperature which is quite similar to lab, which should be 20 ± 2. You should be able to accommodate at least one person who is comfortably works there and who's able to immediately do the test and release and help perform the test and manage it. You need the room, you should have a store, you need equipment, you need reagents, you at least require a fridge, which refrigerator at 4 degrees centigrade, and yes, the most important, the biomedical waste handling area to be, or bins to be placed, etc. Instruments, since it's a microbiology lab, though it is a point of care testing, but in a hospital setup, a hood for handling class 2, at least class 2 clinical samples should be there. Storage room, I've already said, refrigerator, and a computer is important because that will help you transmit the results to the core lab, and from the core lab it can be checked and released. And if you are looking at molecular and instrumentation, you may require a gene expert, biofab, tuner. It depends on what you want to set up. So this is how it would work. A POC, it would be the POC lab is there, a trained operator is there, the patient does usually the self sampling, and within 1 hour the results are given. It is linked to the core lab, and the supply chain, etc. Everything is monitored by the core lab and the instrument supplier, and it is the instrument supplier who looks into it, and the reagent supplier who looks into it. So this is what the model of a POC lab, very much like a stat lab, which would be set up close to the emergency. This is a lab which I was it's called the Dean Street Express Clinic. It's based out of London in UK, wherein it's a fully automated almost lab, wherein the patient walks in and the patient completes a short questionnaire by giving the history on the touch screen, which is there, and the touch screen orders the relevant swab which has to be taken out. The patient does a self sampling, and once he does the self sampling, he collects it, and the instrument again gives him orders what is he supposed to do. So the individual, once he goes into the private room, gives a sample, then comes back, delivers the sample to the port, and it automatically it's processed into the gene expert, and the results are released, and the results are released to the consultant, and the consultant can see it, and the patient can go and meet the consultant and take his treatment. I was quite amazed to see that how everything has been automated through self-testing and a walk-in clinic, automated cleaning, where the patient himself does the test. So these are some oversights when you plan the POCT testing. We forget that what kind of instruments need to be kept. We forget that what kind of manpower needs to be kept. We need to have, it can be very compact space, but we need to make a space for everything, a centrifuge, everything, so that we do not miss out on anything. Then after all this, POCT testing, less time, all this is not enough to have a good POCT lab. You need to have time management so that you make good decision making, you streamline your staff, streamline your processes, increase your physician and clinic matrix as a relative value add, whether you have done any value to that or not. And obviously you take the consumer feedback, whether you're able to retain the consumer, you are getting a better satisfaction index. Resource management, you need to have better bed use. As I said, if you triage, probably you do better use. If you give your diagnosis fast, probably reduce the length of stay and make it more cost effective, and utilization of the beds is better. And medical management, obviously, what is the morbidity, mortality, whether the cure rate is good, and time to appropriate therapy, and the antibiotic usage, the stewardship. So these are all, only doing the test is not enough. So if you look at the other tests like your NAT, ICT, what are the general challenges with these? Your NAT has good sensitivity, but it is a high degree of technicality, which is you require technical people to do the tests. Then there is a power shortage. If you do not have enough power, you cannot use this test. Then the other thing is some of the reagents may require to be stored at 4 degrees centigrade. Though some of these flow systems are working on and negating that, so that the kits and this thing can be stored at room temperature. But then there is challenge. ICT, I have told you, low sensitivity, specificity, multiple kits. So we need to make a technical and an intelligent choice, an informed choice. Syndromic management, they are very expensive. Technical expertise is required to perform the test and sometimes even to interpret the test, especially when you get multiple organisms positive. In respiratory, you may get 4 pathogens positive, so you need to have technical expertise where the core lab microbiologists can call up, discuss on this thing. So these are fair outcomes of POCT testing which have been measured if you look at it. So when they looked at it, I'll go by the influenza one, if you look at it, it impacted the antimicrobial therapy. As I said, most of the infections, be it upper respiratory and sometimes lower, they are sometimes most of the times are viral and not bacterial. So the antimicrobial usage can be optimized in that scenario. And in the sexually transmitted diseases also, CTNG diagnosis helped. And tuberculosis, obviously, whether it's an MDR tuberculosis, XDR tuberculosis, it makes things much easier. So there are different things where the outcome matrix was measured, and in all the cases we have seen that the POCT testing did help in many ways. And I think Dr. Neeraj has already dealt with this quality in a POCT lab, but in microbiology lab, it is very important that you do a quality check of your biosafety cabinet, you maintain the temperature, record the temperature of your refrigerator, room temperature, because most of your kits you will be preserving at room temperature. So the temperature of the room has also to be monitored, including controls, positive and negative control. That's always a challenge. How many controls, what controls? Please make a decision, make a plan for your QC, how frequently you would want to run, what would fulfill the need of the manufacturer and what has the manufacturer recommended. And obviously, whenever there is self-sampling, the patient is sampling himself or herself, a sample quality indicator should be there, very much similar to your RNA-seq in your PCRs and some of these rapid PCRs. And obviously the most important is, if you are using minimal instrumentation also, you will require to have a instrument maintenance. Challenges: enthusiasm of easy to use portable POCT device needs to be carefully balanced. Don't go overboard, don't do a POCT for everything, because always POCT is not what you require. Even then, comparing the test performance among trained lab technologists is important versus non-trained. I'll give you an example of a simple lateral flow assay, which I faced in my own lab. In the lateral flow assay, the time the manufacturer had mentioned 15 minutes. The technologist who was performing it, he was a new technologist, he was a trainee technologist, and he did not follow the 15-minute protocol. He would keep it for 20 minutes. And in the Typhi IgM assay, he would get a lot of positivity. Then when we looked at it and we blamed the kit that the kit was not good, it was giving a lot of false positivity. Then when we did a root cause analysis for this, we realized that probably the kit was not the problem. The technologists thought that probably 15 minutes and 20 minutes would not make much difference, but it makes a difference. So in POCT testing, lab technologists to be trained, to be conscious, is very important. It can make a difference up to 35% is one of the studies which says that is for your group A streptococcus for rapid antigen detection in a clinician's clinic versus in a lab where it was being performed by a trained person. So yeah, this is my personal experience which I shared. There are some ways by which I said there's some instrumentation. If you look at it, you can have an automatic reader which can read probably the lateral flow assay, and so this can minimize the operator variation. So there are various solutions to the problem. And as I said, for the PCRs, there are closed systems which interpret by themselves, which give the results by themselves. You hardly need to do anything. Whatever is beyond the interpretation of the test performed is given by itself. Then is the microbiologist's role of doing the clinical interpretation of the report. For the technical interpretation, there is automation. So there are various solutions to these problems, and there are more coming up. And I'm sure we will have a where we will actually do away with point of care testing. We will all call these testing, and the tax would go down to less than 1 hour, and microbiology diagnostics would gradually become faster. So I have always said, if the bacteria are smart, they outnumber us. So we have to be, if not smarter than them, we have to keep growing so that we are able to have our say in the.
Dr. Sohini has done her MD and DNB in clinical biochemistry and FNB in laboratory medicine. She is presently working as HOD Biochemistry, Redcliffe Lab, India. She was previously associated with Sir Gangaram Hospital, Delhi. Her areas of interest include point-of-care testing, therapeutic drug monitoring, endocrinology, and quality assurance in clinical laboratory. She has publications in peer-reviewed national and international journals and has been invited to speak on various national and international platforms.
So good morning, everybody. And my topic today is point of care testing, present technologies and future perspectives. Point of care testing, as I may say, is a very in thing now, with the market really booming with respect to point of care tests. For the last 6.5 years almost, I've been working very closely with point of care testing with Max Healthcare, because we were in the process of getting the hospital JCI accredited. And that's when I actually came face to face with the challenges as well as the solutions to the potential problems that we might face while we establish a point of care testing network in our hospitals, or any place for that matter, a clinic, a camp, where a community outreach area and the like. So I'll just divide my talk today into 3 segments, where I first discuss in brief about the present technologies, then the future trends that are there right now, and finally I'll also discuss the ways towards establishment of a good quality management system when you are trying to set up point of care testing in a good way. So what is point of care testing? Point of care testing, or POCT, is defined as tests which are designed to be used at or near the site where the patient is located, that do not require permanent dedicated space, and that are performed outside the physical facilities of the clinical laboratory. Point of care is a discipline that is evolving, like I've already told you, in analytical scope as well as in clinical application. It is in fact being said to be growing at a higher rate than the conventional laboratory testing. The principal drivers being a need for speed that is reduced at, improvements in technology, and reduced availability of labor. Resistance to POCT, however, remains, and that is because of its concerns with quality, users not being confident with QC interpretation, and of course, the IT data integration. Assured is the criteria by WHO for a reliable POC equipment, which has already been discussed by Dr. Jain and Dr. Das. So I'll very quickly rush through it. A for affordability, S for sensitivity, S again for specificity, U user-friendly, R rapid and robust, E equipment-free, and finally D that is deliverable to those who need it. So amidst the novel coronavirus pandemic, the importance of rapid testing and early disease diagnosis by POC has really been underscored. So very briefly, this is the list of laboratory tests which are available presently as POC. As we see in biochemistry, it's the acid-base balance and blood gases like pH, PCO2 and PO2 with the help of ABG analyzers, sodium, potassium chloride, ionized calcium, ionized magnesium, a lot of metabolites. Then in hemat, we see coagulation parameters like PT, APTT, then INR, very routinely being used as a part of point of care. Just a second, I'll just choose Yeah. So this is how it is. Finally, the hemoglobin fractions, that is the co-oximetry, again, which this is again seen as meat hemoglobin, then self-meat hemoglobin in ABG analyzers. Cardiac markers like troponin D, tropi, again, very commonly used in your emergencies. Glucose HbA1c, probably the most commonly used instrument or equipment for POC is the glucometer for the diagnosis of diabetes mellitus. Again, minimally invasive continuous glucose monitoring, very frequently being used. Then again, coming to the detection of infectious agents, which has already been discussed, HIV, HBV, HCV, of course, COVID-19, a lot of threats, Plasmodium falciparum and bivax by means of these routine card tests that we do in any laboratory. Though done in the laboratory, they are still bedside or near testing tests, that is, POC. Again, urine diagnostics by urine strips, and finally blood as a part of stool diagnostics. If we look at a pie chart, we'll see the majority of POCs are constituted by glucose testing equipment, that is glucometers, accounting for about more than 50%, around 60 to 65% are glucometers. Remaining around 20% would be ABGs, and the rest are consisting of HEMAT, and HEMAT POCs, urine analysis, infectious disease, cardiac markers, and coagulation markers. Now, going briefly into the technologies for POC, number one is the lateral flow assay, which again may be of two types, that is the immuno-based and nucleic acid-based tests, and on the other hand is the nucleic acid amplification tests, which may be PCR-based or those based on isothermal amplification. I'll just very quickly go through the different type of technologies that are available for POC. One is the qualitative strip-based POC, unit use analyzers, then benchtop POC analyzers, hemastasiological coagulation analyzers, continuous measurement systems, and finally, molecular biology-based POC devices. So this is the very typical and very common lateral flow immunoassays that you see, and this is used primarily for pregnancy testing for detection of HCG in urine dipstick analysis for every possible analyte, glucose, bilirubin, ketone, specific gravity, pH, blood, and protein, which you must be very routinely doing anyways. Screening for albumin, that is for microalbumin screening, for infectious agent detection, like by for group-based streptococcus and the like that we have already discussed. A new product is the lateral flow test for penicillin binding protein 2A, which might be used for the detection of MRSAs. So what is the advantage of using a lateral flow assay? It is the only diagnostic platform that covers the wide range of target profile from level 1 to level 5, has a consistent reproducibility and specificity with rapid outcomes. Due to low production cost, portability, ease of use, and long shelf life, these tests are suitable for use in developing and low resource countries, and a variety of body fluids can be used as samples at small volumes, and analysis of the results do not require additional instruments or expertise, making this technology easily accessible. So what are the limitations or challenges of an LFA? Number one, sensitivity. They are obviously less sensitive as compared to your analyzers. Accuracy of the test relies on the quality and preparation of the antibodies. Analysis time is dependent on the physical property of the sample, particularly if the sample is too viscous, the analysis may take longer. The results obtained are qualitative or semi-quantitative, where some diseases would require accurate quantitative results. Finally, the LFAs are also dependent on immobilized proteins and may pose a challenge due to lot-to-lot variability and antibody cross-reactivity. The analysis takes, now coming to the unit-based POCs, the number one advantage is that the analysis takes place on test strips, but of course in this case a reader is used only to read the result from the strips. Test strips are one-use articles, and the most common types of unit-use POCs are glucometers, which has an empirometric measurement capacity, coagulosens, then INR ratio 2s, and flow time in rhythm. These are all for coagulation analysis. Next is the benchtop analyzer. It's more complex than unit-use machines, and they use different analytical principles, spectrophotometric substrate and enzyme activity measurement, particularly for clinical chemistry parameters, hemat particle counting for immunoassay antibody-based tests, and sensor-based blood gas analysis by potentiometric or amperometric measurements or by optical sensors for pH, PO2, PCO2, iron-sensitive electrodes for the measurement of electrolytes and other blood gases. And this is the one that we are most commonly using in critical care units and emergencies, cath labs, etc. Now, coming to the hematostasiological coagulation analyzers, they are called pseudo-POCs because of their high degree of complexity. Although valid for use in POC, only qualified personnel should be using them and operating them. Examples are the combined analysis of plasma clotting, thrombocyte function, and fibrinolysis by viscoelastic coagulation testing that is nowadays very commonly being done by rotem and sonoclot. Also, platelet function in terms of in vitro bleeding time or via optical aggregometry by PFA 100 and Verify Now. Now, continuous measurement with POC systems, again, you see it very commonly in critical care units by minimally invasive location of a microdialysis catheter in subcutaneous tissue, and most commonly being done for continuous glucose monitoring. So this is how the instrument looks like, where it measures the glucose continuously in the subcutaneous tissue. Now, if we go discipline-wise, we'll see the POCs which are being used most commonly in hemat are the 3-part differentials or the 5-part differentials and PT-INRs. For PT-INR measurement in the emergency department coronary care units, APTT, then for detection of hemoglobin by HemoQ, which is also used very frequently in blood banks, D-dimer detection by, again, to exclude primary embolism and initiate immediate therapy. Viscoelastic assays, they are the new tests which are being done, like I've already described. Thromboelastography and rotem are the ones doing it, where they sort of real-time measure the viscoelasticity of the blood. ACT, that is activated clotting time, again being done in OTs, then your cardiac units, CTVS ICUs, etc. And finally, the malarial antigen. So what are the POCs which are most commonly used in biochemistry? Cardiac markers, of course, both for TROP-I and TROP-T, serum beta-HCG, and urine beta-HCG, electrolytes, renal function tests, blood gases, lactate, PT-INR, creatinine, HbA1c, CRP, lipids, urine strip analysis, and of course the most common, glucose. Now, coming to the molecular biology based POC devices, attempts have been made to use molecular biology methods, mostly PCR, in POCT to automate and integrate all real-time PCR based nucleic acid amplification steps like sample preparation, DNA amplification, and detection, and to use multiple fluorescence dyes which permit multiplex assays for the detection of several targets within a single sample and thereby hasten the process and reduce that to detection. So the amplification for POCs may be done by two ways. One, that is the PCR on a chip, which is a miniaturized version of the conventional PCR. And secondly, by isothermal amplification, where the entire amplification occurs at a single temperature. So there are different varieties of isothermal amplification techniques in POCs like RCA, rolling circle amplification, NASBA, SDA, and loop mediated amplification, which have been very extensively used for the detection of COVID-19, which I'll come to a little later. And finally, the detection endpoint or real time using fluorescence-based dyes like SYBR green or hydroxyl naphthyl blue. But what are the limitations or challenges with using NAT-based tests? Number one, it may be dependent on the type of sample and can be affected by several amplification inhibitors which may be present in the unprocessed sample. So you have to be a little careful about the sensitivity and the specificity of these assays. Secondly, isothermal amplification techniques such as LAMP require more than 3 primers. Therefore, there's a high risk of primer-dimer formation, which can lead to false positives and therefore undermine the accuracy of these NAT-based POCs. And finally, several isothermal NAT technologies are still proprietary and therefore pose a challenge with respect to cost effectiveness, and their availability is limited as compared to the traditional PCR. This is a list of tests which have been used very extensively in India and all over the world during COVID-19, and which has really re-emphasized on the importance of POC in our lives. So one was this TrueNAT, which is microchip based, and CBNAT, again cartridge based, which would give result in about 1 hour. The advantage was that it had a closed system and required minimum biosafety hazards. Isothermal amplification by ID now would give you a positive result in less than around 5 minutes and a negative result in around 13 minutes. Working principle was RT-LAMP, again fast results, closed system and minimum biosafety hazards. LAMP, positive result in less than 10 minutes, negative in less than 30 minutes, high accuracy and repeatability with a single working temperature. And finally, the very indigenous CRISPR-based assay, which was termed Feluda after the very famous detective from Bengal. So the time needed was 30 to 40 minutes, and it was a lateral flow assay based on isothermal amplification with a high throughput on low cost and was totally paper-based. So these are a few examples of a very extensively used molecular biology-based POC devices in the last 2 years. Additional examples are GeneXpert for detection of Mycobacterium tuberculosis, and another under evaluation is the Expert Assay Nasal Complete for detection of Staph aureus and MR assay colonization from nasopharyngeal swabs. So this was about what we have been using over the years and more recently over the last 2 years. Now I take you through the future perspectives before we move on to the quality management system. So what are the goals of development of newer technologies in POC? Number one is that currently available novel POC systems are in part forerunners of a new generation of laboratory systems and will dominate the market in 10 to 20 years time. So we are basically looking at using 4th generation laboratory systems as novel POC in the form of certain novel sensors like aptamer-based plasmonic biosensors, electrochemical sensors, and microfluidic chips. The methods through which you can introduce newer technologies in POC include miniaturization, parallel analysis, and of course, the most important part, that is networking via information technology, wherein you can integrate the data from all the sites, whether it's across the laboratory, across the hospital, in camps, in outreach areas, clinics, or at home with the doctor, and take a consult easily and also initiate immediate therapy to sort of serve the basic idea of using a point of care testing equipment. So miniaturization in the form of microfluidics, chip technology, and electrochemical detection, which would reduce the fluid volume requirement to about nanoliter and picoliter range. Parallelization chip technology, which would open up the possibility of using multi-channels or multiple time points in the smallest space. So something like, enabling 100 or more measurements to be taken simultaneously and thereby reducing time. And finally, like I've already discussed, the networking via next generation POCs to enable and facilitate better communication between decentralized blood glucose monitors, ABGs, and the laboratory or the doctor's IT system. For the future, individual electronic patient files in which laboratory values from various sources can be directly input and linked to other results may also be a way forward. Newer applications for POC now include drugs of abuse like amphetamines, benzodiazepines, etc., which can be performed on sweat, saliva, blood, or a swab test for suspicious surfaces as well. So this is under production. Then smart card, which are thin card-based assays for blood gas, electrolytes, lactates, and hematocrits. Chip and reader for very important cardiac markers like tropi, NT-proBNP, CRP, and TSH. HbA1c analyzer, where HbA1c can be processed in a very small tabletop device instead of the very traditionally used boronate affinity chromatography. Then handheld immunoassay machines using nanoparticles for cardiac markers, parathormone, and sepsis parameters. But all these are in process and I'm sure would really flood the market in the next few years. A fluorescence response enhanced nanodrop diagnosis named FRIEND for infarct markers. And finally, the magnetic resonance detection of paramagnetic and antibody labeled nanoparticles via a spin relaxation signaling assay. Smartphones and wearable POCTs, again, already in the market. It uses a sensor mobile POCT which detects signals from the sample in vitro, whereas wearable POCTs detect signals on the body. Both systems then send quantified results to the clinic via a wireless communication. And nanosensing, plasma resonance, development of new apps will therefore shape the future of smartphone-based devices for diagnosis. Wearable POCT, which is important for people suffering from clinical illness, as they can monitor their health intermittently without the need for going to hospitals or needing trained personnel. So one such device has been improvised by Google, and it's known as Glass by Google, to monitor PSA, HIV, and motor visual impairments. So these are an array of emerging technologies of the future trends that we may look forward to in the form of smartphones, biomems, electrochemical biosensors, and microfluidic platform, which really promise to move diagnostics to a whole new level. Urine strips, which can identify the relevant parameter on your smartphone. Then iPhone glucose meters, which the Apple Store apparently is already selling. The new mobile phone to detect unpleasant odors and the like. Some important parameters which are really in the way of being launched into the market are detection of neutrophil gelatinase associated lipocalin, that is NGAL, test for acute renal failure, galectin-3 for fibrosis and adverse cardiac remodeling, copeptin for early diagnosis of myocardial infarction, and preeclampsia using a combination of placental growth factor, that is PLGF, then SFLT1 and endocrine for early diagnosis of preeclampsia, maybe at home or in the doctor's chamber. So these are all newer technologies which are about to be launched into the market through POC. But in spite of whatever technology you are using or whatever trends or newer technologies come into the market for point of care or bedside testing in the next few years, what remains paramount is the need for quality and competence for point of care testing. Like Dr. Jain has already said, that ISO 15189, the new version, would be replacing the 22870. Yet what remains paramount to the use of POC and to optimize the use of POCT is that the risk to the patient and the facility be managed by a well-designed, fully implemented quality management system. So what is important is that you first decide where you perform the test. POC in your central laboratory or as a real point of care or bedside testing or near patient testing in other places of the hospital, maybe in your wards or in your critical care units, your emergencies or your OTs, in the OPDs of doctors, outside the hospital, in pharmacies or doctor's office, in camps, in schools, offices, or self-measurement at home. So 2, 3, 4 are actually what you call POCs. Now, this is from what we faced over the last 6 years while establishing maybe one of the first POC networks in India. Webinar, I'm delivering a talk. Challenges in establishing POCT. One is quality assurance in what I was telling you is this is the challenges in establishing POCT is the ones that we faced while we tried to establish a point of care testing facility in the hospital. Because our hospital at that point of time was about to go in for JCI accreditation, and JCI as a mandate requires that POC be supervised by the laboratory. So when we went about looking at the POC devices which were available, what we saw is around 88 to 90 glucometers, maybe 5 or 6 ABG instruments, ACTs, that is activated clotting time devices, and then thromboelastograms and bilirubinometers, all of them accounting for around 150 POC equipments, which nobody had any idea about. It was just being used by the nursing personnel across the hospital. So the principal challenge was a quality assurance for setting up quality assurance for optimizing clinical outcomes, then complex regulatory requirements, training of testing personnel, competency evaluation of numerous personnel involved in testing at remote sites, then implementation of uniform quality policy in varied locations across the hospital over which you genuinely had no control, and finally information management, how to get the report across to the doctor, how to get him to immediately initiate therapy, how to document the entire process was the real challenge. We also saw that the potential sources of error were documentation of results in patient records, patient identification, operator identification. Somebody could have actually used that glucometer, but you never knew who. Failure to run a quality control. However much it is said that all POC equipments do not need any quality control, that's absolutely not true. There have been tests which had been classified actually as waived and non-waived, some which do not need any quality control at all, some which do need. So that is where your judgment comes in. You have to speak to your instrument provider, look up the inserts to get your equipments regularly calibrated, then see how you can run the quality control. If it's advised once a month, then maybe get the equipments to your laboratory and then run the QCs once a month, or maybe just train your users to be able to run the QCs. Then next is untrained tester using expired reagents or strips. Very often with glucometers, they were actually not aware of what strips they were using, whether they were within the date or already expired, and failure to follow manufacturer instructions, failure to respond to out of control situations, and finally, failure to observe safety requirements. So what should be your approach while designing a quality management system for POC? Number one, how often and how many levels of QC runs are desirable before processing a sample? What is the cost involved? Are results comparable between operators and from day to day? What were the frequency and quality of training imparted to the users of POC? What were the defined alert or critical values for each device? It is very important to define critical alert values for glucometers and other POC equipments, and it actually varies from your critical alert values of the clinical laboratory. And how could the data from the specific testing process be recorded and used optimally? So the approach towards establishing a QMS in POC would be to identify if there is a clinical need. If no, then reconsider it at a later stage. If yes, select a suitable device based on the user need and quality criteria. Weigh the benefit to the cost ratio. Develop a governance structure and organizational accountability. So you should actually set up a POC committee, which should have your laboratory director, a laboratory POC coordinator, quality manager, then the supervisors of the units using quality control, using POCs, then your purchase officer, your medical superintendent, and the like. So you have a comprehensive discussion about what are the needs of POCs and what is the way forward to optimize the quality process. Then documentation on policy and procedures. So you have to have a documented SOP on how you will go about it. Who is responsible? Accounting responsibility for POC and training the responsible staff are the two most challenging aspects of a POC program. Then ensuring quality control and proficiency testing are implemented. Proficiency testing is required, whether you do it in-house by devising something which is cost effective, or you are capable of associating yourself with a structured PT program is completely up to you. But yes, proficiency testing needs to be done. Then implement continuous training and education. And finally, monitor regulatory and accreditation compliance. So monitoring is very important. And you, of course, need to have a designated POC coordinator who will review the compliance to your training on a day-to-day basis or at least a monthly basis. Now, when I talk of IQC and PT in POC, there are a lot of challenges with respect to QC. So number one is analyzer based, because it is a multi-test menu. There may be multi-test sites and devices and need for immediate availability of result. From the user end, there are multiple test operators, non-laboratory trained operators, non-familiarity with testing process, primary responsibility being patient care. There's no time for quality control, no understanding of QC, and not familiar with QC interpretation. So they do not know. Your nursing people will not be knowing how to interpret an LJ chart. So that's where you have to make it easier for them. So what are the types of controls that are available for POC? One, of course, is the traditional, that is external QC, auto QC, electronic QC, or equivalent QC. But all of these would require interpretation of outliers and initiation of corrective measures. There is also a new age QC, which is available nowadays with certain equipments. That's the real-time QC, where the instrument itself gives you a real-time awareness about how your system is functioning. So how does real-time QC enhance patient care? I'm sorry, I think I'm missing the graph. Real-time QC basically helps you to detect the air bubble. It is a continuous program where QCs are run before every sample maybe for ABG is analyzed. So instead of your 8-hour QC process, what you have is your QC being run every time a sample is run, and then more extensive checks every 4 hours, and even more extensive checks of cartridges, etc., every 8 hours. So that is how a real-time QC. I'm not saying that real-time QC is an option, but if it isn't, then please make it easier for your staff by getting the glucometers to your laboratory, handling the QC material yourself. That is, IQC materials are normally provided with all glucometers. What you can do is devise a program where you get the glucometers to your laboratory maybe once a month and run the IQC and the interpretation yourselves. So how do you increase the make the outcome for patients better with respect to POCs? Of course, there's on one side, there's this increased cost, and if you go for that and sort of compare it with the poorer outcome, then you do not start with POC. On the other hand, is you give a better outcome for the patients. Initially, it might be a little cost inclusive, but finally that in the long run decreases the cost for your society, for the society and your clinician at large. So of course, starting with POC and optimizing quality in POC to make these results reliable and make your clinicians rely more on the POC results would be the first step forward. Where does your role fit in as a laboratory physician? This is where the clinician is at the crossroads, wanting to decide on which step to take next. So that is where our roles as laboratory physicians come in the emergencies, in the OTs, in the ICUs, where by providing the right POC instrument, by optimizing quality, and by giving accurate and precise results, we can enable the clinician to take the right step forward. So these are two articles that we published on point of care testing. One was optimizing quality practices in point of care testing. That was the first from India, which sort of gives you a comprehensive analysis of the challenges that we faced and how we devised a POC program with the help of an in-house IQC and PT program, thereby keeping the cost at check. The second is a Clark error grid analysis for performance evaluation of glucometers in a tertiary care hospital, where what we did was we did an analysis, a Clark error grid analysis for all around 90 glucometers across the laboratory and reviewed which ones were the glucometers that needed to be taken out of action. Then how the PT program helped us in realizing and sort of, making it even sharper by removing the non-working glucometers and replacing them by newer ones. Had we not done that, the older glucometers or the inefficient glucometers would continue to be in practice. So thank you for your patient hearing.